Welcome, everybody. Thank you for joining us tonight. We're very happy to be having an exceptional dentist tonight with us. That is Dr. Germain Jean-Charles, who is an American dentist out of Canandaigua. Tonight, we're going to be having a great webinar about the systematic approach that Dr. Charles created based on bite force and other metric that he's using as biometric standard to explain to his patient why they need a full arch conversion. Now, we're very happy to have you join from everywhere in the world. We're also live on Facebook tonight, and everybody that is attending the webinar and answering the poll questions will be receiving a CE credit and certificate by the end of next week via the email you used to register. Now, tonight, we want this to be a very dynamic presentation, and we want everybody to ask and write down the questions they have for Dr. Charles so that he's going to answer them at the end of the presentation. So feel free during the presentations to write your questions in the Q&A. You can also write them in the chat to us, and we're going to be happy to have them answered for you by the end of the presentation. Now, without further ado, Dr. Charles, I'm happy to leave you the floor and take over for the presentation.
All right, Fred, thank you for the introductions. Welcome, everyone. I'm very happy and pleased to be here tonight. Just as a disclaimer, I have not been paid for this presentation. I just started using that technology, and it has changed so much in our practice that I so truly believe in what it does for us, and I agreed to share that with you in this webinar. I have so many friends and colleagues that have texted me personally and wanted to join this webinar. So I really welcome. As a matter of fact, myself, I'm away with a group of excellent doctors and colleagues, for the ambassador meeting at one of these companies. And I'm very happy that you guys decided to join us. So it's a pleasure to have you on the call. So I'm Germain. I practice out of Canandaigua, New York. I'm an assistant professor at the University of Rochester. I'm a pathologist by trade, and our practice focuses solely on full arch rehabilitation using dental implants. What I have to share with you today is nothing that you guys have not been doing in your practice. It's a piece of technology that I call meaningful. And whenever we incorporate a piece of technology in our practice, it has to do three things for us: help us with conversion, help the patient get better results, and also help the business. So tonight, the approach that we take, it's one that we call an evidence-based approach to both diagnosis and treatment. Treatment planning for us is key. And at the base of the treatment planning, what we're trying to establish is to make the patient understand the value of what we add as providers, especially dental providers, in order to help them in their rehabilitation process. As we do this, what we've learned, it builds the patient confidence, and it ensures very long-term success. And at the baseline, what we have, it increases the practice revenue. And in our practice, what we're trying to do is to develop every single patient that we see into a waving fans, and we really love that. And I'll show you tonight how we use one piece of equipment within our workflow, which composes of many, many, many different technologies that are meaningful to achieve that result. Tonight, we're going to talk about the Innobyte. So that's a poll question.
So, yes, we're going to be launching, Marianne, the first poll question for everybody. So I'll let you take over that, Marianne.
Perfect. Thanks so much, Fred. Thanks so much, Dr. Charles. We're really happy to be here. This is just a question to kind of get sorry, I should put my video on too so everyone can see. This is just a video or a question to say, what are we doing? What type of technology are you using? So we can kind of have a better idea of where you're coming from, how we're going to be understanding what the technology you're using moving forward. So Dr. Charles, you can talk about this a bit more into the presentation you're going to be giving. So I think we've got everyone who answered. I'll go ahead and end the poll and share the analysis so you can go ahead and see where everyone is.
Perfect, perfect. Wow. That's great to know that everybody's using intraoral scanning, especially when it comes to treatment planning for implants. AI segmentation is about 8%.
Yep.
That's great.
Yep.
But overwhelmingly, we have about 60% of people using intraoral scanning. Draw record and analysis, that's great. Photogrammetry, about 8%. Well, that's great to know. And I will touch base on each one or each aspect of these technologies. And some we call disruptive technology because of their potential and what they have done, in our practice.
Super.
All right, here's the list of what we call the New York Dental Implant Full Arch Technological Stack. It's no difference to what you guys have mentioned there. But in our case, every single piece of technology that we introduce in our practice has a critical value. If it does not meet the cut, we just cut it. And as you could see, we use the latest technology for CBCTs. AI segmentation is at the cornerstone of what we do as well. Advanced facial scanning, professional photography, like many of you have mentioned. But now we have quantitative bite measurements. What that is for us is a technology that allows us to visualize the amount of force that a patient exerts prior to enter a rehabilitation. And this is revolutionary for me in our practice. And we do use other technologies such as dynamic draw record. And we have proprietary system that we are developing and testing in our practice as well. And also photogrammetry, which has become, common stay in our practice since about 24 to 36 months ago. And then advanced CAD software that most of us use. And of course, milling system. But lastly, and I want you guys to understand this, the collaboration, if you use an outside lab, is key. If you don't have the proper collaboration with a lab that can support and sustain your operation, treating full arch can become daunting for many of us. And we use these technologies for one and only purpose, to maximize profit. And the reason we do that, this technology allows us a timely, very impactful and predictable delivery. What that means, the patient can come up for initial consultation, and once they fit the profile, and this patient is a candidate for what we do, within a very short period of time, we can put them into surgery and make sure that they get rehabilitated on time and give them impactful results and have them become raving fan of our practice. Then we'll show you with an example that we have with this presentation that only covers that. All right. So one thing that separates us from others is why do we use this technology the way we use them? And what do they do for us? Okay. Number one, predictable and repeatable results. That's number one. Number two, we use what we call an evidence-based approach for both diagnosis and treatment planning. Like we mentioned, this as the first slide, it builds the patient confidence and it increases the practice revenue. So how do we do that? And what is an evidence-based approach? I'll cover this in just a few words. The difference between medicine and dentistry is having a patient come in and see you, and you see the patient on the path from having some serious debilitation on the way to terminal dentitions, and you still have to convince them to buy treatment. And that treatment is one that's going to add so much value and change the entire paradigm for the systematic problem that they have, which is their medical health. So what we've done, we changed the paradigm in our practice. So we use the evidence, and the evidence has been built even when the patient was a prospective patient at the marketing level. We culture these patients, we educate these patients, and then bring them in when they become real patients. As they become patients, we already have all the evidence to make sure that person understands the value that we're trying to add to their life, which is when they're sick, because they'll tell you, or their confidence is affected. They'll tell you, or their functions are affected, and they'll tell you, or they can't live with themselves. But yet, why is it so difficult to have this patient engage and accept treatment which going to serve them? When you have an approach that can serve that, it only brings you to that raving fan quality of your patient. If you treat a patient and they refuse to engage with you, and they refuse to say, hey, this doctor has done this quality job, something is not right. And that's what we try to achieve with every single patient in our practice. And it is part of our philosophy. It is part of our delivery. And we make sure patients understand it before they even come into the practice. We don't chase them. We work with them and find a way to really rehabilitate them the right way. So, as we asked earlier, do you guys measure the bite force in patients? Have anyone used that technology? If you have, what is it? What is the Innobyte? So I'll let you watch this video real quick, and then we'll cover a few things in that. All right, what is Innobyte? I'm not sure if many of you uses the Innobyte, and what the Innobyte is for us is this radar. It is that, that piece of equipment that have brought the clarity that we've always missed. Having a way to quantify, to know how much force can a patient exert at the time of their baseline assessment. We've never had that in the industry. I don't know if anybody have used any other form of technique of instruments. We've used the tech scan. We've used many different other pieces of technology to understand the bite, to understand the forces that patients exert. And one thing that doctors typically would face, one problem they would face is having a patient rehabilitated and that patient having functional problem, fractures from appliance, problem with temporomandibular joint, and not being able to know exactly what is the true etiology of this problem. The Innobyte has solved that problem for many of us. What it allows us to know and understand is at the time of inception, when a patient comes for evaluation, we can now know how much force, what's the maximum force that a patient can exert to sustain their function. And once you know that, you take that information and go into treatment planning and now gauge the patient and rehabilitate them based on that information. And once you have a patient at initial consultation, you do something like that, their eyes just went like this. They have not been exposed and seen and being able to know why their function is so affected. So that is the key information that we use to not only make the patient aware of their conditions, but also if for any reason the patient so decide to not engage with us, we use that information as part of the evidence that we gather to then educate them later and bring them back. So we'll show you through a case how we utilize that information at inception within our workflow to make an impactful response toward that patient, because that's what we're trying to elicit from all of our patients. They sit down, they come as a consult. As we do this, we want them to have that impactful response from something that we use that would then help them engage with us.
Dr. Charles, I'm just going to go ahead and throw in a second question, because it's exactly what you're talking about. Like, are we currently assessing anything with bite force? So I'm going to go ahead and launch our second question.
Perfect.
To get an idea of that. So we're just going to give it another 5-10 seconds, and then we'll go ahead and share the results, and you can kind of talk about those. Okay.
Perfect. Perfect. So in our practice, every single patient that receive a consultation, having the bite for registration is key. We have to do it. And when we do it for a single purpose. And the purpose is to tell the patient, you are at a phase where your function is either sufficient or deficient. If it's deficient, we have a way to engage and solve that. And when we do, it allows you to bring your functions back. Along with that, you have the benefit of the aesthetics as well. So now, roughly 12% of the participant uses some form of bite evaluation prior to treatment, but most of us, 36%, don't. And contact paper, well, that's the conventional way we typically do that. But if you gather a patient, occlusion, let's say, with contact paper prior to surgery, what benefit would that, give us into the workflow? T-scan, it's a current technology that we used to use on a regular basis, but I'm glad that I found the Innobyte in other form, like dynamic jaw tracking, that right now, for us, we don't have to use a T-scan anymore. It is still a viable technology, quite powerful. If a doctor has it, and I'm sure that that's going to add a lot of benefit to their practice. But now, with the new wave of technology, we have other ways to quantify that. You don't have to guess anymore. There is no element of guessing.
Super.
All right, what we're gonna do next here, I'm gonna want you guys to meet this patient. His name is Nicholas, and Nicholas has given us consent to use his information because of the impact this has had on him. As you could read, he's a 40-year-old Caucasian male, very nice guy, great personality. When I met Nicholas, he came from his cardiologist, who referred him because Nick had significant severe pain and debilitation in his orofacial region. And this has been bothering him for about 4 weeks. His cardiologist is very concerned because Nick has congestive heart failure. And Nick has met a beautiful young British woman that really wanted him, to seek help because of his pain. And he does not feel confident being around that girl, new girlfriend, and he was just not happy. So Nick is taking Eliquis and digoxin, as you see, and he uses some recreational marijuana to sustain his pain. He denies any drinking and also does not have any drug allergies. And below are his vital. And what we do for every single one of our patients, we have an entire workup for them. It's a medical workup that covers everything. And that information came before the patient even entered the practice. And we use that information to develop a treatment plan. Before we get to the treatment plan, the patient has to accept treatment. But despite Nick having all this problem, and Nick wants to be rehabilitated, there's one factor that all dentists, especially full arch dentists, faces. And that factor is, are they going to pay for it? And a lot of time we dance on the questions to ask the patient. We spend an hour talking about the x-rays, talking about their history, talking about everything. And we never really address the problem, which is, are they going to pay for this treatment? As a rule of thumb, patient knows this type of treatment costs a little more. So what we do, we harness these technologies, and then we let them have that impact on the patient, and we educate them as we go. So what's next for Nick? Let's see. We had our initial conversation, okay? And for us, this initial consultation is the most important interaction because it's the culmination of a number of pieces of data point that we already acquired before they become a patient. We use that information because we know this did not happen overnight. And then we start training these patients. Okay? Debilitation leads to terminal dentition. It's a multifactorial etiology. It just did not happen overnight. As you could see on the right, Nick came in on April 11th, which is just a few months ago. And we had that initial conversation with him. And what did we do in that? We used the same workflow that we had. We dedicate an entire workflow for consultations. It's a pre-consult workflow plus the consultation workflow where we use the medical history, we use the radiographic evidence, and we also use a very powerful, detailed intra and extraoral examination. And then we add the Innobyte on top of it by measuring their maximum bite force. We take that all information and we fit it into our proprietary system. And then the goal is to sell the treatment. A lot of dentists don't like to talk about selling. We're not truly selling, but we are actually selling. If we don't have patients, we can't even help them. So Nick came in on 4/11. We had that conversation, and Nick decided not to go on with treatment, I believe, because I'm looking on the right, it has a second workflow that says consultation back September 20th. Let's go to the next slide. Nick came in, okay, and this is the initial consultation that we had with Nick. He went home and did not accept treatment, and we're okay with it. But whenever a patient comes in for initial consultation, it does not stop there. That's just a meet and greet for us. We actually prefer a patient not to accept treatment at the first consultation. Why? It allows us to understand them better. By the time they come back, their behavior is ready for what we do. So let's watch this video. Is there a video there, Fred? Now we have the bite force. Nick, I would like you to insert it inside the mouth for me, please. With your front teeth in the front, okay? And then you're gonna bite hard for me. Thank you. And then the second time, bite for me. Thank you very much. And then the third time, I want you to bite as hard as you can, please. Okay, thank you very much. So now we have a recording of a maximum bite force of 45 Newton for Nick. Thank you. So whenever we have a patient bite on this, and we want to make sure that they understand what that, what that translates into. So our methodology is really, like I mentioned earlier, is to have a very dedicated educational approach, in order to help, treat that patients. Like I mentioned, we follow an evidence-based approach for both diagnosis and treatment. And what that means, knowing that the etiology of these debilitations or failing dentition is multifactorial, so it does not stop only at the patient level. So the patient a lot of time have a number of allied care practitioners or providers that they go, especially for a patient like Nick. He's seeing a cardiologist for congestive heart failure, and Nick is taking a lot of other medications. So if we were to say Nick and do what we have to do, that information need to translate into an impactful report that Nick and the allied care provider can understand. So what we do, we gather that information and then we put Nick into what we call a follow-up process, which is a follow-up workflow. Nick came in, it was by April. We gathered all that information using the radiographic evaluation, using the medical questionnaire, and also using the bite force. And then we do a follow-up process with Nick. And you guys are gonna see what happens, with a patient like Nick in a minute.
Dr. Charles, I'm just gonna go ahead and do another poll question because you've shown us some of your workflow, and I kind of want to see, who else has a workflow in place? Is this something that we can are they learning from what you're showing them, like some of the steps that you just showed in some of the previous slides? So I'm just going to go ahead and launch our third poll question.
Perfect.
At the same time, I invite everybody to write your questions. If you have any questions for Dr. Charles in the question or the chat for us, we're going to be happy to answer them. We already have a few, so please keep them coming for us. Thank you.
Perfect. This is great. It's really interesting to see who's got them and then defined as what you've got with them as well. So this is really interesting.
Perfect.
I'll go ahead and just a couple more seconds and I'll go ahead and share that.
Wow, about 46%. One of us has an established workflow for our patients. That's great. 39% somewhat in the middle, and about 14% no. So folks, I gotta tell you, I gotta be real with all of you, okay? If you are going to engage into dental rehabilitation using dental implant or any aspect of rehabilitations, these are things that you must have in place. It's a defined workflow that takes the patient on what we call a journey. It's not even a treatment, it's a journey. Why is it a journey? When patient comes and see you as a practitioner, what they're looking for is not dental implants. And I think most of us know that. What they're looking for is an experience that changes their life, the way they see themselves or the way others see them. And that way, a lot of times they don't like. In order to really satisfy those, the best approach is to already have a prescription that fits that bill. And that prescription, we call it a workflow. In our case, our process does not include just one workflow. It includes 5 different workflows. We have the consultation workflow. And right after the consultation workflow, as you will see in this presentation, it follows by what we call a data collection workflow. From data collection, we go into surgery. And from surgery, we go into post-surgery. And after post-surgery, we go into testimonial. The testimonial, yes, it's part of a workflow. If you want to develop waving veins, they gotta talk about it. And patient would agree to talk about an experience that has added value, changed their view of things, and build the confidence that they needed. If you can provide that to a patient, no patient ever comes to a clinic or write on Google that, hey, Dr. X have excellent margins. They don't care about margins. But they'll tell you, oh my God, Dr. Charles' office is really nice. And these people are very nice. They treat me very well and look at my smile. Whenever someone can stand and say that about you, that does not mean you are the best or ever. They make others understand that you have been the best for them. So having a workflow that you can count on is key. It's critical. That's cornerstone if you want to really build a successful practice where others, can come and learn a little bit. All right, so now with our methodology, Nick, as I mentioned, did not accept treatment. Irrespective to him accepting treatment, we cannot just stop the workflow there. So we use that medical approach that is based on the evidence that we mentioned. We gather all this evidence, and then we go ahead and start the educational process of the patient. But you can only just educate the patient because a lot of time the bottleneck does not just stop with the patient. A lot of time it stops with their allied care providers. So what we do, we use a very meticulous follow-up and extensive consultation process to make sure that whoever is engaged in that patient's health is aware of what we're dealing with. And we make sure that the patient in the mix is informed. The conversation is not for the patient, but the conversation is geared at really evoking a very, very thought-provoking response from that particular patient. When you do that, the paradigm then shifts. And you want to shift that paradigm because you want that patient to see you as a doctor that's going to add value to them. As a result, I've never seen a doctor. Many of my brothers are physicians, and a lot of times they laugh at me. Whenever they see patient, either for consultation or for treatment, they never had to do anything with financing. And a lot of times I ask them why that is. Yes, there's 1+ factor, which is the medical insurance route. But yet, if a patient has a serious medical condition that requires intervention, patients typically goes forward. Why is it so different for what we do when we tell the patient, you are at the terminal phase of dentition? If you don't take action, your systemic health will be compromised. So all we do, we use the exact same thing. We can choose to put it through medical, which we did with Nick, but we don't have to do that. Because once the patient understands the value of what you're proposing based on the critical technology that you use and the impact that it has on their systemic health, they will engage. They must engage. And we have them engaged. Just having done that, we have boosted our revenues by $90,000 quarterly. So now if one were to say, why would you invest $4,000 on a piece of technology? I'll tell you, out of the $90,000. Because it helps us not only treat the patient, but also help the practice increase its revenue. So any little piece of technology that we use, either single or in conjunction, helps the bottom line. And if you really want to build a successful practice, you need a tool that's going to add that value not only to your workflow, where you're going to have significant results, but also into the practice. It benefits us all. That's what I like about the Innobyte. And the Innobyte is one of the technology, but at the consultation workflow, it has the most impactful, response for both practice and patients. Patient can believe that they are so debilitated. In practice, benefit from the conversion when the patient understands and follows this process. Next. So now, this is what we call a follow-up consultation letter. Regardless, patient accept treatment, don't accept treatment, everybody's gonna get. And this is AI-driven technology that we use that gathers all the information we put through. And within that, we have the patient x-rays, we have the patient note, we have the patient critical information, and then it brings this report, and this report is communicated to, again, if the patient has 16 doctors, every doctor gets a copy. And when a doctor gets a copy, we request a response from the doctor. Having that response, then we let the patient engage because the patient will get a note from the doctor asking them to come back and discuss that information. And that report is a 16-page report. And that report has everything that we've acquired from that patient since they were pre or prospects. They're on Facebook somewhere, they're on Instagram somewhere, on TikTok somewhere, on Google somewhere. When they become, you know, a good candidate and they come in, we use that stack of information and do this. And what we did this is pretty simple. Let them know that their problem is multifactorial and their problem is no longer a dental problem, but rather a systemic problem. Because it's a systemic problem, we want them to take this approach at rehabilitation. We engage with their physician on their behalf in order to benefit them. Now they come in, please be at our mercy and we're going to help you. That's all the report. That's all. The purpose of that report is to let them know of that information and they get a copy of it. So if you could see, we saw Nick when back in April. Within 2, 3, 4, 5 weeks, we engage and then see what happens next. Okay, I'm here with Mr. Nicholas Morris, and we are processing his bite just to prove to his medical insurance that we actually did record the original bite force that he can exert. He's been in pain from time to time in the mouth and having some discomfort. And due to his heart conditions, it is highly advisable that the insurance take this as a medical necessity to help Nick rehabilitate himself, because congestive heart failure being such a morbid condition could affect all organ system and can lead to fatal outcomes. So now we're gonna go ahead and take a bite registration that would also quantify and tell us his ability to bite and chew on solid food. If his numbers are not within the range, it tells us that Nick needs rehabilitation. And when we do rehabilitate Nick, we will repeat the test and prove that his functions have improved over time. So now, guys, the good news about this, which is very important, I hope you guys understand. And Nick, in the case of Nick, you know, I'm not sure if a lot of you are familiar with what medical necessity is and what evidence-based approach is. So in the medical world, in order to treat a patient, you have to have what we call a diagnosis. In dentistry, it's the same, but a lot of time, our way of diagnosing a patient varies from one provider to another. So now in the medical world, when you use the evidence-based approach, it's quite different. And that's what separates dentistry from medicine a lot of time. So in medicine, so once you have a diagnosis, that comes with a diagnostic code. A diagnostic code would then lead to what they call a procedure code. So if you were to take a cardiothoracic surgeon in India, for example, and a cardiothoracic surgeon in Canada. So all of these doctors have been trained, I take India, just I'm pretty sure in the United States, that's the way. If you were to take it in 2 separate states, but I'll take India as an example. If a patient has a particular diagnosis and that patient requires a specific intervention, each one of the surgeons is going to use the best evidence available at that time to do that procedure. So now it's all about provider skills. So in dentistry, we don't have that. However, when it comes to full arch, if a patient is totally debilitated So the one thing that we need in the mouth to establish the medical necessity is three things. One is infection. Infection is defined by any intraosseous lesion that you find within the jawbone. The second is resorption or bone loss. As a rule of thumb in the medical world, if a patient is missing 3 or more teeth, at least moderate to severe resorption exists. And the last one is malocclusion. If you do lose 3 or more teeth, the same convention applies. You will have a form of malocclusion. So now a patient with systemic conditions, and you have them radiograph, and you look at the x-rays, establishing the medical necessity is not difficult. However, you have to prove that evidence. And in the case of Nick, he has congestive heart failure, and he has some other morbidities in his medical history that we were able to use to make sure that we can establish the medical necessity for him. But when you do go treat a patient towards medical, that does not mean the patient does not pay. The patient still has a portion. In our case, one arch costs out around $36,000. If I'm going to treat a patient like Nick, his portion is going to be at around $21,000. Because on average, on medical, if you know how to do it and do it well, you still can collect at around $13,000 minimum, you know, for one arch, which shows that for Nick. But using this workflow that we have, even if we were not to collect on medical, Nick would be a great case. So now you see Nick came in back on September 4th, based on our follow-up process, which has been quite significant, and he accepted treatment. Sent the office a text. He wanted to inquire. It says, what is that little thing that we did for him? And when we question, that was the Innobyte. Said, Doc, I've never seen anything like that. And I can't believe that I'm only, you know, at 45, and this is severe deficiency. A patient like that, based on the graph, based on the reference chart, cannot have anything. A patient that would come and the patient would tell you, Doc, I'm in a lot of pain. And you go ahead, you do the Innobyte on them. Now you explain to them, this is why you're in a lot of pain. This is why this is not working. So if you look at a follow-up consultation workflow there, patient agrees. When they agree, we have this set of data that we're gonna have. You know, we have their financial, we have the new patient packet, we have the medical release. This is a workflow. We cannot just go blind. In our practice, we don't just treat patients or the number of patients that we treat a month. We count patient as the number of patients that we complete a month. And we do that in conjunction with all the partners that are involved in our workflow, as you would see next. Go ahead. So as it has been explained to Nick, and as his test result, Nick has what we call a critical bite deficit because he only had 45 Newton registered, so he has a critical deficit. A patient like this definitely is in need for rehabilitation, and our test will prove later on how he has improved over time. And the reason that we do this, you know, this is intentional. We want the patient to see exactly where they are. And I make sure I not only do this, we didn't record this because of this webinar. Every single patient that we put through the Innobyte or any piece of our technology, we record them. And we use that information to remind them and educate them of the value. If they don't do anything, what may happen? We're not trying to scare the patient. We totally believe a patient like this patient will get worse if nothing is done. So now patient accepts treatment, our workflow continues. The third workflow is, the second workflow is record collection. And I'm sure a lot of great doctors on this webinar, as you mentioned, about 38% has a workflow established. In our case, the next workflow is data collection. And as data collection, we know the data is going to get to the lab. So we have a lab request. In our lab request, you guys heard of this, garbage in, garbage out. If you don't take your time and have a very stringent data collection process that's going to set you aside, you will be frustrated. If you don't provide the lab with what they need, you will be frustrated. Patient will be frustrated. So that's why we establish, for any critical aspect in this delivery, we establish a workflow. The lab and we have a perfect communication, and they understand what the doctor wants. They understand what I'm trying to achieve. They know about my standard, and we work together. It is such a dynamic. The lab is part of this delivery. You cannot isolate the lab and send just, no, it's part of this delivery. And at this point, we are 100% digital. So everything has to be perfect. As you could see from record collection, the next is surgery. In our practice, in 24 hours, we can achieve that. Patient get closed on 28th of September because it's going to medical. A medical patient, sometimes the medical insurance requires 30 days in order to get the approval for the letter of medical necessity. So in Nick's case, and because of our relationship, it's a little short. So from September 20th to October 12th, Nick is already scheduled for surgery. So now we have the lab data, and then we push Nick to the next level. And the next level is the lab request is part of the record collection, right? And in that lab request, as you could see, we already have all the data, and the lab tells us what they're going to do. It's what this is our own convention. You know, the patient is going to go for what we call an upper surgical, appliance, and it's a fixed surgical appliance for the upper, and then that is the patient initial, Nick Morris. Okay, and next, let's go to the surgical workflow next. All right, next we go to the surgical workflow. Same thing, guys. In the surgical workflow, there should not be any guess. It's not at the time a patient comes and now you're trying to figure out whether or not you have this form or that form or something. No. Way prior the patient gets into surgery, you know, this is all. Everything that is grayed out is done. Everything that is red, like you could see, the only last thing missing for Nick is called the medical claims, the medical claim submission. And since surgery was done on the 12th, on the 16th, that claim form is out of the door. A medical claim form is different from a regular dental claim form. You know, it requires a battery of information to send to the insurance in order to maximize your reimbursement. So we took Nick to surgery, following the, a stringent digital workflow. And let's see what happens next. I'm sure that's not new to any one of us, right? It's the same thing. We got our surgical markers there. We go into surgery, take some teeth out, and then place some implant. After we place an implant, we make sure we get some multi-unit there. In that case, we use photogrammetry, but we have some proprietary technology that we also use. And then we take the tissue and get it into a fixed upper. If anybody would question why did we leave these two teeth there, especially when we temporize patient, we want to leave proprioception. When a patient has two good teeth, we sort of keep them temporarily and see what they do with the temporary appliance. And a lot of time they do pretty well. Sometimes we keep them, sometimes we take them out, depending on how they turn out to be. And in Nick's case, having to use one piece of technology has convinced him to come back and get rehabilitated. And we really love this because of the impact it has on the patient. Before, it's a chase for the doctor and the practice to try to get this patient to understand the value. Now, when you harness technology, it allows us, you don't have to chase. Let the patient understand their inaction can end up in some critical deficit of their, not only their function, which is already affected, but their life and their health. So in a nutshell, I believe that covers it all. We have a few more slides, right? And the remaining slides, I think, would cover, you know, what would a case like this cost? What would the margins be? If you were to use a case like this, what would the margins be, guys? Literally, for a case like this, patient invested $21.44, and our expense were about $916. And on total inventory cost, and we also invested at around, you know, less than a few $100 in an apartment, and that leaves us with a margin of about $20,000. And that's the way you want to do this. If you can't maximize those margins and make this thing work for you, something is not right. But again, you have to have the right collaboration. You have to have the right lab. In our case, we use Evolution Dental Science, which is up in Buffalo, one of the best full arch lab that I've used. We have our own in-house lab, and they support us all the way. Why? They have the best in the business, and they understand this technology, and they've used it, and they provide, you know, this access to help the doctor, you know, as a partner in business. And we use them, you know, they're part of our workflow. We do have our lab, and our lab could not be better if we did not have a partner that understands what we're doing the way we want them to. You know, when you set your standard, doctor, and the lab understands it, it only makes you better. It just only makes you better. And this is the final. Whenever we rehabilitate a patient, the one thing that helps us close their case, you cannot tell and promise to a patient, we're going to rehabilitate you, and don't show them what's the results say. So let's see what we get using one piece of technology and see what it does for Nick. Keep biting and then let go one last time. Let go. That's what I love about the Innobyte, folks. A patient that we take in that has 111, I believe, when we started, and just right after rehabilitation, we haven't even sent the patient home yet. We know we registered about 553 Newton of force. That is just a hair close to normal. You understand? And this gentleman told me the fact that he could see, you know, his deficiency in terms of what he can bite and what he cannot bite, and knowing his exact number was a game changer for him. Is that what you told me when we met?
Yes, sir.
And he went home, came back, and today look at where we are. Show the smile for me, Nick. And we just did this. And very soon, we'll do the bottom and get you in full rehabilitation. Nick?
Yes, sir.
You're a superstar.
Thank you. Thank you very much.
In a nutshell, guys, that's another patient. Every patient that we do and we put through this course, all we gotta do is eliciting emotion. And if you go online, you're gonna see this patient early on starting giving those reviews of how this thing has changed their life. It's not me, it's a team approach. But that team involves the technology that you use in your practice as well. This young lady here, I don't know if we have a video about her. The lady had could not even bite anything, was in a lower denture and a few failing upper teeth. And look at her now.
I don't have to screw with them right now.
I know, so cute.
And I don't even have my makeup on.
No, I want
We
you
can
to
do it
enjoy
again.
this. How do you like that, my lady?
I love it. Thank you.
No, you deserve it. That's what we said we were gonna do. That's what we did.
Yeah, you did.
You like that?
A little bit.
That's it. Makes me want to cry, folks.
That's really wonderful, Dr. Charles. Thank you so much for this great and informative presentation about your practice and your workflow. Now it's going to be Q&A time for everybody. So please, again, we have a few questions already. If you have more questions for Dr. Charles, now it's time to write them down. So I'll let Marianne manage the questioning. I think she's going to start by answering the few we have already. Start asking them to you, Dr. Charles.
You got
Yes.
it.
So, hold on, let me go ahead. A couple that we've got throughout the webinar. Thank you so much. It was really nice to see. I really appreciate it, Dr. Charles. Thanks so much. So with increasing discussions around oral health, can you elaborate why understanding a patient's bite force has become a critical aspect in modern dentistry?
Well, that's very good questions. So these are key things that have been put aside. One key thing about bite and bite evaluation and functions, you don't have bite, you don't have a life. And a lot of time, patient would tell you, Doc, I would like to eat this, but I can't. I'd like to do this and I can't. And a lot of time you would have a patient that is breaking everything. They're boxers. The patient comes and see you, they have good teeth, but these teeth are down to zero. And a patient like that becomes a full arch patient. But if you go into rehabilitate a patient like this, you don't have a tool that tells you why they got into that place in the first. You are looking for trouble. So when you have a patient with excessive force and you have a patient with low force, knowing where you can actually put this patient, and there was a great presentation by Dr. Haggie, by the way, where you have to understand the basics of occlusion. Are you going to restore a patient in CR? Are you going to restore a patient in MIP? Is the patient partially dentaless? Is the patient dentate? What has brought the patient to where they are? Is it perio? Is it some other factor? Is it systemic? Understanding those basic principles, that's what makes bite and occlusion the cornerstone of full arch rehabilitation. If you want to equilibrate a patient, you need to know where are you going to equilibrate that patient. You go blind, you might pay the price. Having to redo and redo and redo and redo. But if you have that clarity by having a little piece of equipment, when I met Innobyte and I purchased this piece of equipment, I could not believe it. Again, this was introduced to me by my lab. And they said, hey, Doc, I'd like you to try this thing. Overnight, I didn't even buy one, I buy two. And I think a lot of my colleagues knows that. When I like something, I don't buy one, I buy two. And the reason I buy two is for what it has been doing for us. It gives us that clarity. I don't want to know, is this bite okay? Yes, patient has protected, good occlusion, balance, anterior guidance, everything looks good. Can the patient work with it? Are they breaking? Are they not breaking? Occlusion and bite is the cornerstone of any rehabilitation you have. Why? It puts the patient, it puts you, the TMJ, and the muscle of mastication where they belong. If you want to know, you know exactly where to put the patient. Am I going to rehabilitate this patient in CR? Am I going to rehabilitate this patient in MIP? Cornerstone. We use two technologies that tells us no guess. Innobyte and another thing called module. And that's for another conversation. I hope that covers the question.
For sure, for sure. I really like that. Just kind of going along the same lines as, and I'm just reading, but the question says, as a dentist, how confident do you feel when making treatment decisions when reading the analysis from the Innobyte? So I guess this is kind of going into treatment planning that you're having any other aspects of material selection that you may have from kind of taking into account the bite force?
I like the question. I really do like the question, but because as an educator, and I do have a lot of resident doctor under my guidance, you don't answer a question by a question. However, what's good about this, remember what we said, folks, before we start this, the evidence that you gather prior to treating a patient will lead you to proper treatment planning. It's an evidence-based approach. By having, number one, a cone beam CT. Second, you have the patient intraoral scanning. Third, you have the bite force, maximum bite force. You measure it. Third, you have everything about their jaw position. You have the Bennett angle. You have the the expressive movement. You have the protrusive movement. You have the maximum opening. By having all that information, you even have the facial scan. It is sufficient to say this patient needs to be here. And that's what technology does. It removes that factor of, am I gonna do this or that? No, you must do that. And that's what we use. We try to eliminate that factor. So when it comes to treatment planning, if you don't plan right, you may not reach the outcome. So in our case, treatment planning, diagnosis and treatment planning is key. Not until we have that, we can't. The good news is that vertical integration that we have. I can see a patient today, our system allows us to do that entire planning within just a few hours. As you could see with Nick, we saw this gentleman on the 12th, on April 11th. By the 20th or something like that, we get to treat him. And we know in 90 days, this guy is gonna be out the door. That's it. And our lab can attest to this. A patient comes in, we don't treat patient or the number of patients we treat a month. It's the number of patients that we finalize a month. And I hope you guys hear this. And a lot of doctors will tell you, hey, I do 20, 40, 50 arches a month. That's a lot of appliance that's gonna break on you if you don't have a systematic approach to get them out of the door. People can say whatever they want, appliances, they break. But when you have a really good workflow that keeps this patient from here to here, it removes, that for you. I hope that answers the question.
I think that's great for sure. I am going to launch our last poll question, which is just basically like, are we interested? You have a really defined workflow. And I think one of the things that we would like to highlight on is people who would like to maybe learn more about the workflow that you have. So I'm just going to launch our last poll question to say, okay, who would like to learn more about Dr. Charles' complete workflow? Because then at least we know we're going to be following up with them. We know that maybe this can be something that we're looking to do for another webinar that we have that's going to integrate the Innobyte technology, that's going to integrate all of the other protocols that you have in place that I think could be really beneficial. So hopefully we can get something like that set up in the coming months because you've been so generous with your time. So I think that could be really, really helpful. And I think we've got plenty.
I mean, it's pretty clear, Dr. Charles, I think, from what we can see in the results, right, Marianne?
Yes.
Well, before we even get to this, I gotta give a couple of shout out. I have a lot of good colleagues and friends and good people, especially now I'm fellowshipping right here down here in Punta Cana with the group of phenomenal docs. and all of them focusing in enhancing the patient experience. And I really love that. I really, really, truly love that. And guys, I'm glad that everybody signed up and they wanted to jump in. And I have colleagues from throughout the states. I mean, we got people in Syracuse, people in Seattle, everywhere. And we have the great Dr. Germain Jean-Charles with us as well, I believe, is my partner in business. And he has been part of this from the get-go. And for all these colleagues, thank you guys for signing up. And I'm not trying to sell anything. I don't get paid for this. And you know me, guys. If I believe in something, I just go with it. The Innobyte has changed things for me. From the day that I learned this from Evolution Dental Science and from my good friend and colleague Andy, I said, that's a piece of equipment that now the Innobyte is part of our workflow. I can't work in practice, will not work in practice without it. What it does, it helping me go business. And anything that could give an edge to that workflow and help the patient on top of it, it's a bonus. I would recommend this, no hesitation, zero hesitation. I love it, it works for me. I'm not the only one. 10 to 15 of my colleagues are using Innobyte now. And if you were to ask them, they become believers. I don't want to convince them. I'm glad that they see the value for them, for their own practice. And I'm really happy to see that. Thank you all for signing up for this. Knowing about the workflow, our life is like this. Mi casa es su casa. If anybody wants to learn anything about this, we're very happy about it. And my contribution to science is to help colleagues understand what I do. If it can help them, so be it. Again, thank you all for being here. I'm very happy. This has been quite informative for me. Thank you, Fred. Thank you, Marianne. You guys have quite a good piece of equipment and I love it and I will continue using it. Thanks, Evolution, for bringing this to the surface to me. And thank you guys. And I would advise, hey, if this has value to you, just go with it.